today we have a very cool program with Dr. Chris Holland. He's talking about how to do corpectomies with an elegant, same setting, prone position procedure using the benefits of a robot integrated with navigation. More about that later, but I'm really pleased to welcome him here. Dr. Holland is in Carolina at the Neurosurgery and Spine Associates Institute, and I'll introduce him in greater detail later. He's going to join us here as our visiting professor for a couple of cases which we've pulled together. Before we go into those, we again want to recognize our great team here at SSF and our audience around the world at our 8th annual Spine Trauma Summit just this last weekend. Friday, Saturday, we had well over 1,000 direct views. That was very cool. We had an all-star cast, and Dr. Holland will be happy to hear that Dr. Andrew Daly was one of the co-chairs, now 8 years running, and we had a phenomenal highlights course on basically spinal cord injury, osteoporosis, and a special focus on lumbopelvic injuries with Professor Schildhauer from Germany. So that was a great thing. You can catch those lectures if you missed those on our or in our SSF library. This weekend, led by Dr. Patrick Johnson, we have the 7th annual SSF robotics course, everything cool in spine. And as always, Dr. Johnson's put together who's who of great, phenomenal people who are really the difference makers in terms of taking us into the next level. So those are some of the outlooks and looking back. And again, good morning, Dr. Holland. Can I just have an audio from you?
Yes, good morning. Thank you so much for having me. I'm excited to see some cases here and then give you guys a short presentation on some prone lateral experience.
Yeah, hopefully it's not short because we want to learn all we can. And Dr. Skuin is going to join us shortly. He's worked on that certainly in the lab and I think in 1 or 2 cases, but our experience is nowhere close to yours. So we'd love to pick up some tidbits. As always, we start with a couple of cases, and I think Dr. Hicks is going to come up front, and he has prepared a case to discuss the issues surrounding cages in the front sometimes. So Dr. Hicks is from Alabama, and he's done a great job. He's our Administrative Chief Fellow. James.
Great. Thank you, Dr. Chapman. First case here, we'll jump straight into it. All right, so moving immediately into the case. So Mr. M, he's a 78-year-old male. Status post, 2014 T10 to pelvis fixation. Did have several levels of interbody work anteriorly with some fixation there, and then now presents with low back pain and bilateral lumbar extremity symptoms. This is examination. He has some bilateral drop foot symptoms and also some altered sensation specifically to that left lower extremity, but also some to the right lower subjectively. This is his original construct, AP and lateral, obviously with an extensive construct, and you can see the interference screws anteriorly wedging the previous grafts in there. We'll go on to a CT, and we can see somewhat obvious cause of his low back pain or continued pain. He does have some hardware loosening at the lower end and rather obvious non-union to L5S1. Again, this is several years after his original surgery. And just kind of before we go on to what we did, just want to see if there are any comments on differential or anything else that we would be thinking about with his L5S1 lysis here.
Jim, did you get the upright scoliosis standing films on him again?
Yes.
Because one of the key things that ails this man is that he feels that he can't stand up anymore. And he basically, this is an extremely functional 78-year-old, I think.
Yes, he's a very robust guy.
So he's a philanthropist. He travels the world for all sorts of projects. I think he was in Rwanda for an irrigation project and went somewhere else for malaria prevention. So he's a world traveler. He's been a very active man. He's had medical problems. You can see he's had prostate seeding. He's had cardiac issues. I think he's stented times whatever and has a valve and is anticoagulated.
I think he has some wires going to his heart too.
Yeah, he has. Yeah, exactly. So, Chris, this is a increasingly common problem. We've had very functional patients who have defied their chronologic age and have had other organ systems fail and have had significant spine procedures done. And then something starts not going right. What are your thoughts in terms of those who critique that we're doing these major surgeries on elderly patients?
You know, unfortunately, I have a lot of these patients in my practice as well. I think as we're, doing a better job of keeping people alive longer, and many of our patients in their 70s and 80s now remain active, we end up in these situations where we're doing what would previously maybe not even be considered in that age group, these reconstructive operations. It sounds like this guy had his surgery a few years earlier here, but there's always that risk of either chronic pseudoarthrosis, failure, proximal failure, and once you've started in these patients, and they continue to age and remain active, you end up having to consider significant revisions. So that it's quite challenging. I think I have a number of these patients who are younger than their stated age. This guy, it sounds like he's more active and healthier than most 78-year-olds, despite his long list of chronic medical problems. And in North Carolina here, we have the opposite as well. I've got patients in their 50s that aren't surgical candidates because they're so unhealthy. So it's definitely a challenge. I think it looks like even on these upright x-rays that the rods are no longer fixed to his distal screws, and he's got clear degeneration at 5'1" with osteolysis. You wonder, is this just a Charcot joint here down at this point with chronic instability, or is there an underlying indolent infectious process or something else there as well? It doesn't look like it from the CT, but that would obviously be a concern.
Absolutely. One other question, Dr. Holland. So this patient, Jimmy, was about 6 years out or something like that, and he was actually very happy.
About 7 years out.
Yeah, 6-7 years out from his index surgery. And he's actually, literally a poster child of a successful surgery, a major reconstructive surgery. And he just started getting worse like about a year ago. He couldn't stand up straight anymore. He got increasing fatigue in his back. And again, he started getting foot drops. How long do you follow your long fusion patients? What's your rule? Does it 2 years and then come back as needed? Or do you kind of put them on a surveillance protocol of sorts?
It depends. I like to see them at least out to 2 years to start. And then at that point, depending on how they're doing, I've got some patients that, at 2 years are doing so well, have no issues whatsoever. They're young and active. And I release them knowing that they're reliable and they're going to come back if they start to have issues, especially if I think I've got solid fusion and I've confirmed that with imaging. There are other folks that I worry about that I tend to bring in at a minimum once a year in an ongoing fashion, just because I have a sense or a feeling that they're going to get into trouble at some point.
So this patient had a colleague of mine do a front back fusion, and the front was done in good old carpentry craftsmanship fashion with peak cages and I think, from what I know from this colleague, some autologous core and interference screws. And that surgery was pretty traumatic for that patient. And this was not a straightforward anterior procedure. So in addition to some radiation from the local seating and external beam, apparently, there were concerns about going back into the front. As you correctly identified, the pelvic screws dissociate from the rods, and the S1 screws, if you go to the CT, Jimmy,
Very loose.
they show loosening, and Dr. Hicks is working on a project of quantifying screw loosening. Can you go forward to the CT?
Yes.
Jimmy, did we get sed rate CRP to just screen for infections? Were there any hints at an infection in there?
I'd have to double check. I know we took cultures intraoperatively, which ended up being negative, but he had no constitutional symptoms. I don't think we were very concerned about infection, but we did send definitive cultures for that.
Do you happen to have the CT? Yep. Sorry, you go first.
I would say, I'd certainly, with the degree of degeneration there and inflammation with his prior anterior approach, I would also be worried about going in from the front there. You know, in these cases, when they have this severe chronic degeneration in motion, and you get all of that inflammatory tissue there in the prevertebral space and retroperitoneal space, it's very difficult to come lateral or anterior in those patients. Just because everything is so stuck. And if you add in his prior external beam radiation, I'd be quite worried about it. Was there a reason initially why he didn't have interbody fusion at 5.1, where, you know, anytime I have these long constructs, that's where I'm worried, right? You're worried about proximal failure, and you're also worried about pseudoarthrosis at 5.1. It looks like he didn't have any interbody work done there initially. Is that the case?
Actually, you don't have the benefit of all the images. He did have a 5.1 peak spacer. He had an invisible phantom spacer put in there with a wedging screw. That was. It's not fair to you because yes, he had that in there, and it just shows how unforgiving the 5.1 motion segment is. All the biomechanical forces concentrate there, and while he healed beautifully at 3.4, 4.5. 5.1 just dissolved basically, and we now have a plastic phantom spacer floating around with a tight stainless steel interference screw in his S1 space, and nothing much else. So yeah, no, great point. And the surgeon in question was known for his craftsmanship and liking to put the largest possible ALIF spacers in. So we can assume that there is free floating plastic in there now.
Okay. The other thing I'll mention is I've got 2 or 3 of these cases now where at L5S1, and 2 of them were actually not even in long segment fusions, but just L4 to S1 or L2 to the pelvis, where they've developed this osteolysis. And in some of those patients, it's been quite early. One of them had a standalone anterior approach at 4.5 and 5.1, and began with BMP in the titanium cages, not PEEK. And developed this osteolytic process at 5.1, which was really, I'm not sure exactly the underlying mechanism for that. We went back and stabilized her posteriorly with the thought that potentially this is a motion phenomenon. And it looks like the osteolysis is progressing within the disc space. So not quite as severe as this here, where we know there's motion because we've got construct failure. But I have seen some peculiar cases of osteolysis with really no clearly defined underlying etiology. It's a strange phenomenon, and it's hard to know how to address that. I mean, clearly here this construct needs to be stabilized and grafted again. But I have seen that a bit, and I'm not. I puzzle over those cases a little bit myself, trying to figure out what the process is there.
Yeah, so you mentioned a lot of good things. And again, obviously, we have to think about an opportunistic nosocomial type infection. There is a complex process combined with instability and progressive inflammatory disease. At this point in time, James, I think the defect zone was like 30 millimeters. So we have a pretty substantial cavity in there now. We measured that.
It was about 28 to 30.
I know you'll talk about preoperative preparation with a robot and navigation aids. We have the Hicks-Schlaudruff planning machine, which basically measures out all the angles and holes and things like that. So pretty substantial cavity in there. How would you then fix this cavity? We've talked about the front having been kind of a problematic exposure the first time around, and we now are dealing with a radiated field with EBT, and so not a pleasant thought. And the man is a very intelligent person. He was not keen on, basically his question was, how are you going to get back in there, doc? Because he was under the assumption I want to get in there. So how would you treat this now? We have a pretty substantial gap, in the front. We have a loosened piece of plastic floating around, potential for infection, and an unstable lumbopelvic junction.
Yeah, for me, this is going to have to be a posterior approach with a partial or complete L5 corpectomy. The good thing about having a peak cage up there and not a titanium one or otherwise is that it can be drilled apart or removed in a piecemeal fashion, as opposed to having a titanium cage or something else up there, which you would not be able to remove very easily from the back. I would also certainly put S2 alar screws in, and probably at least 2 points of sacral pelvic fixation below, and a quad rod construct across this segment once we've done the disc and vertebral body work. And in terms of stabilization from the back, either 2 small expandable corpectomy cages or 1 large, depending on the defect, once you've cleaned out all of that inflammatory and cartilaginous material out of there, to make sure that you've got solid end plate preparation to ensure good anterior column support and fusion up front.
All right, so Dr. Hicks, drum roll.
Here we go. So very similar to what you had mentioned. So got a revision T-plif from the back. We end up dominoing up onto the L2. From L2 downward was revised, and then we dominoed up to the construct above. We did redirect those S1 screws and got better purchase with new pelvic screws. And those are modified iliac there. And we were able to get 2 expandable, very nice cervical cages in bilaterally to create a rigid construct.
So yeah, so we used titanium expandable cages. We did exactly what you talked about. We did a very wide L5 root release to the sides. We used osteotomes to get a stable L5 foundation, basically resecting the lower half of L5 into stable, healthy looking bone. We cut off the upper end of S1 with osteotomes. We used a thoracoscopy irrigator system to wash out everything. We sampled everything. We left that stainless steel screw in S1. It seemed to be entirely solid. I've actually drilled those out before. And then we have a pretty substantial, highly unstable cavity. And together with off-label bone morphogenic protein and an abundance of bone that we tamped in, we, with some struggles, I must say, in this case, we've done this a couple of times now, insert these cages horizontally and then turn them 90 degrees. That's still something where I want manufacturers to help us a little bit more, have something that can be inserted really small and raise them up. And we redirected S1 screws. We were able to find very good passage spaces. We did formal SI joint fusions. You see some of the telltale signs of bone graft. We just do open bone grafts into the pelvic joints, and then expanded those cages back out. We didn't do quad rods. I'm a great fan of those, but here we felt that we had reasonable stability that hopefully will not backfire. And the patient, how did he do, James?
He did very well. Yeah, he was had no neurologic deficit post-op, was doing well and ambulating within a couple of days. Actually very happy.
Yeah, so that's, it was very pleasing to see and hear from the patient, most importantly, the impact of mechanical stability, because he said that he was immediately happy to be able to get up around again. He'd again compensated for his mechanical back pain for a long time. It's commonly assumed that long-term back pain after fusions is just inherent to the problem. As you said earlier, Dr. Holland, it's an ongoing issue. Obviously, there may be something percolating. We have Dr. Tariq Sohail from Lahore, Pakistan. Tariq, good morning. Actually, good evening for you. Happy tomorrow.
Good evening. Thank you very much. A very interesting case. I think I would have done the same, but at the same time, I just want to ask, was there any culture sensitivity taken? Was there any result out of that from the culture sensitivity of the fluid taken from the fluid or any tissue from the front?
We found no signs of infection. We did microbiology, we did pathology, we had a immediate smear, and we treated it like it could be an infection. Again, we spent a fair bit of time, easily an hour plus, just with debridement, wash out, clean out. And again, we put these pulsatile irrigator systems from thoracoscopy tools, and then run a very large number of saline with antibiotic solution products through there. So we're prepared for it. We didn't find it. Had we found it, we would probably put PMMA with, so methyl methacrylate with antibiotics
It was grossly infected, but it would,
and to stabilize the cavity. We did not treat the thoracic transfer lesion. He does not have myelopathy, and he actually on myelogram had a clear cord passive space. That's the other thing I wanted to talk about. But just in light of the potential that there could be an infection, we did not attack that top part. We actually just opened up the lower half. Do you have an overview shot where we can see the scout view, where you can see the attachments? We basically used attaching rod systems. Yeah, no, we just basically opened up L3 to pelvis and were able to attach to the previous rod system.
It was a very nice construct up top, the way those dominoed on. But yeah, unfortunately, I don't have a slice of that.
Yeah, that's okay. So, but mechanical instability, long-term deficit. How many of those dual cages have you done, Dr. Holland?
Not many. You know, I've had a couple of cases like this where I've always had the plan, you know, to either put one or two cages, depending. I think anterior column support is critical in these cases. And so it all depends on the access I have and the quality of bone that I think the cages are sitting on. I think here I was really worried with the degree of degeneration and the size of that space. That a single cage wouldn't be sufficient, and so I think I would have done exactly what you guys did here with the two cages. If I am able to get a large cage into the midline, and I've got good bone to sit it up against, I'm okay with a single cage. But I have had cases like this where you have to put two cages in, and I've had the same challenges that you have, especially with the second cage, because once you've got the first cage in, getting the second cage in and rotating it is a challenge because you don't have as much space up front to do that. And so it's kind of a game of back and forth. You know, you're moving both cages around, potentially out of position to where you ultimately want them in order to maneuver them into position, stabilize them, and then expand them together. So it's challenging for sure, but it looks like, at least on what I can see of the postoperative films, you've got good anterior column support there. And in a guy that looks like he has a relatively normal BMI, this guy would be a rarity in North Carolina, but looks like he's a fairly normal BMI, which is also to his benefit.
Yeah.
Rod, any thoughts from your end?
Jens,
Yeah, 1 second. Dr. Osgood is speaking. Yeah.
No, this is a very difficult case. I think it was managed appropriately. I think, you know, it's always tough to revise an ALIF with a, you know, large footprint and a big gap like that. I mean, I'm sure it probably was very unstable in the OR.
It was. We took our time.
Yeah.
All right, Tarek.
is it symptomatic from the top level of instrumentation? There appears to be accelerated or exaggerated degeneration at the two level, at the proximal, you know, vertebral and construct junction. Is he do you think in a view of that he may develop a PJK over the period of time? And are you worried about it, or is patient symptomatic?
I'm always worried about everything, but you may have missed it. We were not sure whether he'd have an opportunistic infection at L5S1. On the myelogram cuts, he did not have cord compression. Clinically, he had no myelopathy. So he has some radiographic wear and tear. But we, by intention, because of the potential of infection, only addressed the lower half at this point in time. The upper half we wanted to leave untouched in case that there would be an infection. Again, so far he has no signs of an infection. So if he becomes clinically symptomatic, which again, I repeat, he is not, we could then do the upper part at a later point. But right now it's a radiographic breakdown, you're quite right, but not a clinically relevant one.
Yep.
Thank you.
Thank you.
And then just one thing I was going to mention, and we touched on this, the instance of osteolysis in the presence of BMP. It may be somewhat dose related. In this particular series of cases, biopsies did confirm no infection. It was interesting that they followed these patients and seemed to have resolution 12 weeks after surgery. as opposed to being several years out. But they did recommend possibly using less BMP in the interbody space as compared to the posterolateral space for fusion. So it was just an interesting, possibly related to our patient. So.
Did they specify the dosing where they saw it and the dosing that they would recommend? Because that would be interesting.
Right. I think it was somewhere around 1.5 milligrams, just off the top of my head in terms of what they were placing in the interbody space, and then nothing more than that. I hope that sounds right, but that's what's popping in my head from their paper, about 1.5.
Usually it's around 2. If you think of the dosing and how the sponges are broken down in most of the kits, it's usually around 2 milligrams. And for lateral or anterior cages, I think that tends to be the dose that most people use. I'd be interested if you all use a different dose. There's been a lot of attention paid to dosing in the cervical spine, obviously, with the initial issues there. And we published some work a few years back showing that there is safe dosing in the cervical spine for high-risk patients, and that's much lower. That's at usually around 0.5 milligrams per level. So I think that's an interesting paper. It would be interesting to see why a higher dose of BMP would cause more of an osteolytic reaction than an osteogenic.
Right. It's very interesting. There are cases out there very similar to this, and it's just something to pay attention to. So.
Great. Great case. Thank you, Dr. Hicks. Great discussion. Dr. Holland, if you have a couple of those cases, maybe we can pool them together, because we have, I think, 7, by my count, dual cages. Our administrators hate it because they are fairly expensive per level, and they calculate everything out nowadays. So, but maybe we can pool those together, because as clinicians, when anterior approaches are a problem, this becomes a true challenge. Talk about anterior column support. Dr. Mauricio Avila is another great fellow of ours. He's an enfolded resident from the University of Arizona, and he has a different slant on an anterior column problem.
Okay. Good morning, everyone. So we have a 72-year-old male presented initially to our outpatient spine clinic for 2 months of continuous back pain. Before presentation, he had a fall at home from a ladder. He was trimming some trees and then he fell. Initially, right away, he had severe back pain, and he actually went to an urgent care where they obtained some AP and lateral x-rays. He was discharged from the urgent care with some over-the-counter pain medications. And over the course of the next 2 weeks, his pain improved. He kind of kept at it, kept working. But after a few more weeks, the pain was still there. And then he went initially to his primary care doctor, and then the primary care doctor sent him to our interventional spine physicians, physical medicine and rehab, who picked up some things on the x-ray and said, I think you need a spine surgeon consult. So they obtained a CT and they sent him to our clinic. He did not have any bowel bladder symptoms. And as I mentioned, some of the other kind of pain meds were helping with his pain, but did not resolve. Got a prior medical history of BPH, hypertension, and a newly diagnosed ankylosing spondylitis. On exam at the time in our clinic, he was basically neurologically intact. These are the x-rays that he obtained at the urgent care where he was discharged from there. And the report says that he had some scoliosis and possibly a compression fracture. That was the report from those x-rays. This is the CT that the PM&R sports medicine team obtained before sending it our way to our spine clinic. And you can see there, the lines represent the axial cuts there. So he has a partial heel fracture at L1, and there's listhesis of T12 over L1. But more importantly, I also want to point out the posterior elements. Point the pointer. The posterior elements here, you see this calcification of the supraspinous ligament, and then there's discontinuity here. So this is also a translation type fracture, but as you can see, there's bony bridge here and here. So he's starting to heal the fracture, but it's quite a complex fracture there. Just for completion, we'll also obtain a CT of the thoracic spine. You can see the signs of the ankylosing spondylitis here with the osteophytes anteriorly and posteriorly, and again, seeing the fracture with some vacuum phenomena at it. We also obtained an MRI to evaluate the cord and the intercanal space. You can see he does have O-cut moderate. He still has a little bit of CSF around it, but he does have stenosis at that level and also quite severe on the foraminal level. So the question at this point is, what are the treatment options? Again, it's been 2 months since the fall. Basically, he'd done his own kind of observation and conservative management. Should we put this patient on bed rest? Should we brace him? Should we provide a surgical fixation? And if the third option is the one, how we should proceed?
If you can go back again. So, Dr. Holland, is this just us? Is it in the water here? Analogous to my previous question about having increasingly aging patients with really bad backs, do you have that same increase of patients with ankylosing spine disorders like AS or DISH or hypertrophic osteoarthropathy? I mean, it's crazy here.
Yeah, we see an awful lot of it here as well. The other end of that for us too is that a lot of the patients in North Carolina are still smokers. And so we've got patients with really bad spines, really bad spinal disease, and all this ankylosis, which in those patients, we tend to see diminished bone quality anyway. And on top of that, a lot of those patients in our population are continuing to use nicotine and nicotine products. So we have it basically from both sides. So it's a terrible issue for us, and it takes what would be some fracture patterns that would be managed conservatively. It makes them much more high risk, and both from a non-operative and operative standpoint.
Would it surprise you to hear that this patient, that it came, this is a physician actually, that it came as a complete surprise to this patient that he had ankylosing spondylitis, and that this was missed in not one, but 2 different ERs, and it was identified as a compression fracture. And our the outside, the physician, sorry, physical medicine colleague also did not know that this was ank spond. Is this a surprise to you?
It's not that surprising, unfortunately.
It's remarkable to me, but again, it's easy for us to say. But for me, as we talk about fracture classifications, for me, one of the first triage things is next to level counting is, do they have an underlying inflammatory disease process?
Right.
Now, here we have a mess. And again, Dr. Chinmay Patare, good morning, Dr. Patare, or good afternoon, says operate. And so how do we treat this now? So we have an ankylosing spondylitis disorder, it's 2AS, expected really bad bone. The lumbar spine still moves. The patient is very keen on not losing low back motion. And there's clearly some neural element compromise. We have a 2-level fracture involvement now. One segment has completely dissolved. The other one is kind of collapsing. This is probably by AO criteria. Mauricio, how would you classify that?
I will call it a C-type fracture, just looking at the posterior element, the translation between this kind of fused supraspinous ligament, translating forward. There is some burst component here, but I think to me, this is the key part, the translation. Makes it this a C.
So AO type C injury. So what would you do about this now? We have 2 levels involved. Was that T11-12 or what was it?
T12L1.
T12L1. So T12L1, L1 being the dissolved vertebra. Mm-hmm. Complete ankylosis above, incomplete ankylosis below. What are your thoughts?
So from my standpoint, I think anterior column support here is critical. In patients without ankylosis, the anterior column support is what's going to allow you to do a shorter construct posteriorly and incorporate fewer levels. I get nervous when patients with ankylosing spondylitis because the bone quality is ironically low despite all of the ankylosis that's there. And you tend to have to make a much longer construct in order to stabilize it. You also have to think about things like fenestrated screws and cement augmentation in the levels above and below the fracture here. I like a lateral approach for these types of fractures. There's significant kyphosis there across the fractured segments. I think the footprint of those lateral corpectomy cages is much larger than those expandable posterior corpectomy cages. And so you get much more anterior column support. So I would start with an anterolateral approach. And depending on his anatomy, whether it has to be transdiaphragmatic or subdiaphragmatic to reach the inferior end plate at L1 at T11 rather, and the superior end plate at L2. I think starting there and then doing a posterior construct going at least 3 levels up and at least 2 levels below with cement augmentation would be where I would start.
Great. And by the way, Dr. Patara kept texting, thank you again, and he felt expandable cage with screws, rods, and augmented with cement, so echoes a lot of what you said. Talk about expandable cages quickly. Dr. Najjar previously asked for that L5 partial corpectomy case, why did we use expandable cages? Why not local bone graft? So how can we justify the use of expandable cages? Are they truly justified in terms of their substantial cost and possible biomechanical failure rate relative to just putting, for instance, bone graft in?
So I think from an expandable cage standpoint, I think there are a lot of benefits. Particularly, we saw in the first case where it would have been difficult to get structural graft in posteriorly into that space, as well as bilateral support. Here as well, the footprint of these expandable cages, especially the lateral expandable cages, are quite large. When you have to do some dynamic correction here, you're going to be able to do that much more effectively with a cage that you can adjust in situ to do that correction. So I think personally for me, I'm a huge fan of expandable technology. I think there are a number of benefits, and particularly in this case here where doing a 2-level lateral corpectomy here, I'm going to want that expandable cage so that I can adjust the amount of correction across that transition there. So for me, the value is justified. There are lots of things in spine surgery where we can argue the value, but I think expandable corpectomy cages, there's clear value there.
Would you feel comfortable doing this in a simultaneous prone position approach?
I would not. I take a rib on my way in usually at the lateral approaches at this segment, and I like to take that rib for use as autograft, but also to aid in the exposure. It's very difficult to do that in a prone position. Doing a 2-level lateral corpectomy across the thoracolumbar junction prone would be incredibly challenging to do. Depending on his particular anatomy, you may be retropleural or transpleural at the upper part of the construct. And for me, I would do this in a direct lateral position.
Dr. Hart is joining us. So first of all, expandable cages justified by the extra cost. Bob, you're a senior member of ISSG. Have you looked into expandable cages in terms of cost, risk, benefit ratios?
Yeah, so first of all, I apologize. I've been negotiating with the OR front desk to try to get an add-on case in today, and I'm sure that resonates with a lot of our audience. So I'm sorry I missed the first case, but this is a great case. I agree with all of the comments I think that were made. I do use expandable cages sometimes. I'm still a big structural allograft user and autograft user, and I would definitely harvest a rib and place at least one rib strut as a spanning autograft in the corpectomy defect. The only other thing I would say is I would do it slightly differently. I would do the posterior first. That's become my my go-to approach. And I think with modern osteotomy techniques, we can get this nicely realigned from the back and stabilized. And then I would do the corpectomy, whatever is left or whatever needs to be done from the front as a second stage. And I usually delay that about 4 to 6 weeks so the patient has recovered nicely. And I think whatever you put in there, we have to have something that's biologically effective in terms of bone healing. So an empty cage or a cage that's just filled with DBM, I think is probably not sufficient. I'm going to want allograft and or autograft, and probably BMP in the front. And I wouldn't argue about the economics of the expandables necessarily. They are more expensive. They do save time in my OR when I use them. They can be very effective. My main thing would be, just filling the space with metal is not an effective solution.
Great point. Drumroll, Mauricio, show us what's going on.
So I'll show you, this is our post-op imaging. So we did all posterior corpectomy, and we actually went, I think that's 4 levels above, 2 below, providing that anterior column support.
Now, I must say, on the lateral, I was not pleased when we deployed that cage, how that cage nested. And I know I'm responsible for that, but we tried to play with that and adjust that a little bit. And in the end, I made the executive decision that we will keep it. So, Dr. Holland, if you can go back to the image prediction, is this going to fail or not? I had a nice deformity correction, but the cage nesting I was less than pleased with. We did very large, bore almost bicortical screws below. Is this going to fail, or is it going to hold up enough?
Hopefully not fail. The alignment overall looks good. The alignment's much better. And how was the bone quality intraoperatively with the screw fixation? Do you feel like you had adequate purchase? It looks like you did not have to augment your screws.
We were prepared for it. We actually had the set available, but I forgot what those were, 8.5 screws at the bottom. We put very large, almost bicortical screws in. So we felt actually reasonably assured. At the top, in the thoracic spine, they're frequently just sponges, so we did 4 levels in there. How'd the patient do, Mauricio?
He did well. 2 months later, he had minimal back pain. He was only using some acetaminophen, some Tylenol, and was wearing the TLSO support. He was back to his hobbies, but a recent chart check, we saw that he broke his hip, so he's been very active. But from a spine perspective, he's been doing well.
Yeah, he's virtually asymptomatic, and returned to his very exuberant hobbies, and we've negotiated with him to not climb on trees anymore. So despite that cage not looking quite beautiful, my intraoperative decision was, after about 2 or 3 adjustment attempts, the cage had found a nesting spot. Short of doing a further corpectomy, I felt it was strong enough, and it actually, fortunately, held up that way. So we got away with that, but the main points are ankylosing spondylitis recognition in the first place. We have to do a better job, I think, educating ER doctors, radiologists, and colleagues who participate in spine care about ankylosing spine condition recognition, and being a little bit more vigilant about possibly intervening early surgically. The surgery itself was actually relatively atraumatic. I don't think we, thanks to expandable cages, even had to ligate a root. By memory, I don't think we had to ligate any roots, maybe one root like T12, but I forgot that. We did not want to come from anterior, so we went through transpedicular approach, like what our colleague said. And yeah, this is a late healing film, so he actually healed quite nicely. We're fortunate. But all the points made, such as possible cementing, we felt were very apropos. Any other comments, Dr. Holland? Yeah.
Do you get on some of these patients where you're looking at a construct that you're not potentially as happy as you might be with, do you get a CT at 6 months or at some point to look at their fusion? Do they let you sleep a little bit better at night? I know most of these I'll follow with just x-rays unless there's a concern for a clear issue, but sometimes some of these patients make me a little bit more uncomfortable, and I find myself getting a CT at some point to look at fusion, just to give me some assurance that that it's been successful.
We think exactly like. We have a low threshold towards getting that, not too early, but any question of radiolucency, festering problems, they're frequently dealt with much better if we find it early. So at 3 or 6 months, we will do the same thing. We'll get a non-contrasted CT scan in complex patients. Bob, do you agree with that?
I like to, yes, usually at about a year for me, just to verify fusion, as was said.
We have one
Yeah,
last.
I like to catch them. I like to catch them before they fail, if I can. And so sometimes, you wait till they fail, and it's a much bigger issue to fix. And so if you can get some information early and either feel better about it or worse, I think that's good.
We have Dr. Jonathan Plumer here from Germany. He's a research fellow, and he has another case with a different slant.
Morning. Yeah, I'm presenting a case of a 27-year-old female, and she was on the way back home with friends when they had a motor vehicle accident, and she was passenger on the back seats, and the car actually flipped on the roof. And initially she was ambulating on the scene after the crash, and she got home the same night with a taxi. And the next day she woke up with severe back pain, which got worse over time. So she went to an outside hospital, and she was then referred to us. On exam, she was neurointact, denied any bladder or bowel dysfunction, had a post-void residual volume of 1 liter when she arrived here. And she further had lower abdominal pain, which began the day after the accident, and nausea, and also a tender lower abdomen with a seatbelt, actually a large seatbelt sign. And her lumbar CT showed an A3 fracture of L1 and a breast fracture of L2. And there was also mild retropulsion in the spinal canal, and the C-spine and T-spine CT was clear. And here's also a selected axial cuts of the CT and MRI, which show that the PLC complex was still intact. And furthermore, in her initial abdominal CT showed no free air, no small bowel dilatation, but her bladder was distended. And her further workup showed this image, which basically showed an ileus with distension of the colon and once more a full bladder. So what is our plan?
Nice. So, Tarek, I don't want to put you on the spot. You're a fellow AO disciple. You helped us develop the global AO spine system. We internally struggled quite a bit with classifying this injury. What do you think this is? This is a little bit difficult, right? So lap belt sign, clear, pretty substantial fracture. Reassuringly, the patient walked away from the substantial car crash, but again, she clearly just had a lap belt on. She did not have a shoulder belt. And she's neurologically intact. She has excruciating back pain now. She can't pee right. She has a tense abdomen, but nothing is perforated. So what is this in our AO world? How should we classify this?
I think it's a potentially unstable fracture, and though there is no retropulsion of the fragment, but I think there is certain degree of, there's no significant retropulsion, but there is appear to be some fragment which might push back over the period of time if not addressed adequately. I would go and stabilize this even with the short segment stabilization, and treat it that way, because if we leave it alone, this might go into kyphosis, and that will lead to some neurological symptom over the period of time when she's up and about without any protection.
So Dr. Holland, South Carolina, from Lahore, Pakistan to South Carolina. So you heard the story, reassuring that the patient walked away. There's no motor deficits, no hyperreflexia. There's clearly some integument concern, but nothing is perforated. She is retaining urine. She is evolving in an ileus. She's very uncomfortable from this. She has that infamous seatbelt sign. The MRI is kind of weird. There's not a high signal, not a clear disruption of the posterior elements. The fracture is extremely hard to understand. This is the burst actually goes into the canal. So there's a burst component that goes coronally and sagittally. So this is clearly kind of a multi-dimensional bending, twisting injury type mechanism. The facet joints looked okay. And again, the interspinous ligament actually on MRI looks good with fat suppression stir sequences carefully reviewed. I'm just giving you the fast forward. The patient is posteriorly.
Yeah, I'm concerned with the acute urinary retention and severe ileus without a clear compressive lesion. I didn't see the MRI, but it sounds like the MRI there wasn't an epidural hematoma or something there that's worrisome, or a conus contusion or something like that. With this type of a bizarre fracture with kind of this vertical component in a couple of different planes, certainly and extending through the posterior cortex, I'd worry about an epidural hematoma. And so it's good that we have the MRI to rule that out. This fracture, I think, would need to be stabilized. There's no question. And I think it will likely heal given the bony approximation. So a short segment construct in a young patient, I think, is reasonable. I don't think that this patient would require a corpectomy, even though there's a multiplanar fracture there. I'm more comfortable fixing this posteriorly and allowing it to heal. I didn't get to see the discs very well in that MRI. It's quite small for me. And so if there's not significant or dramatic disc disruption above and below the fracture as well, then I'm a bit more comfortable stabilizing the fracture.
Putting you on the spot, Rod, did you get the case description? So neurologically intact, except urinary retention, significant ileus. Positive seatbelt sign, young, healthy, 24-year-old. She's an accountant. Bad experience at a bad date at night with a flipped car. Walked away, now has severe back pain, urinary retention. Stabilized or not, we have a hard time classifying this as somewhere between an A3 and there's no epidural hematoma. There's no traction injury to the conus. That's another thing we think about. So flexion distraction or burst fracture, somewhere in that gray zone in between. What would you do?
I mean, I think it needs, just the mechanism injury makes me very, nervous. I think, I think you have to stabilize it.
All right, Dr. Hart, stabilize. Young 24-year-old girl, really bad date, 2 a.m, car flip on the ride home.
Well, she's got to modify her, her personal approach to her dating regimen. But besides that, I think this is clearly an operative fracture. And I think the coronal deformity here dictates stabilization independent of how we classify this and what we think about the posterior column. I think she's not going to like that going forward if we don't straighten that out. And I go back to potentially the Holdsworth classification, which was before the Dennis or Denis classification. So that tells you the kind of the era. I think he did a beautiful job of describing the conus injuries versus root cauda equina injuries at this level versus a mixed neurologic picture. And I'm not sure this is neurologic, but if it is, I think it's a conus injury and avoiding injury to the nerve roots. And I'd also be worried about devascularization or some other intra-abdominal injury given what she's describing. I guess the last possible thing on my differential would be just a reaction to opioids if she's had them, because she's probably pretty inexperienced in maybe not previously exposed to opioid medications, and maybe that's the cause of the ileus. I don't know, but it's certainly an issue that deserves a thorough workup.
So we have a consensus. This is rare in medicine. We all agreed on surgery. The question, Dr. Holland, is this is an L1, L2 injury. How high, how low would you go? Would you fuse or not fuse?
So I think I would go shorter with her. So this is L1, L2. I would be okay going 12 to 3 potentially, really just one above and one below, and getting at least a screw or two into the fractured segments themselves for stability, at least unilaterally. And in this patient at that age and with the fracture pattern like it is, I would try not to fuse her with the option to potentially remove hardware later once I have CT confirmation that the fracture itself is healed. I think that's a reasonable option in this patient.
Now, we had papers both from Ray Jacobs in the 80s and from Neil Kahanowitz in DC about rod long fuse short or not fusing. And again, the results were very equivocal. They did not have any great outcomes improvements, range of motion, etc. They couldn't quantify an actual improvement over fused patients. Now, there were substantial methodological issues, but still, in the literature, I've not seen that validated well. In our MIS environment, where there's a lot more just instrumentation without fusion, do you see that validated now somewhere? Do you know of any publications that I'm not thinking of?
I don't. There's not good data out there for it, and for me, I always consider it in younger patients, and it also depends a lot to me on the fracture pattern and whether or not there's a ligamentous or disc component. I've been burned by patients where there's been some disc disruption in addition to the bony fracture, and those patients have failed short segment fixation without fusion as a result, and so. I look at those factors when I'm thinking about it, but in a patient that does not have significant ligamentous injury, disc disruption, and there's good bony approximation of the fracture where I think they're going to heal pretty robustly, I try not to fuse them, especially at the junction here in somebody at that age. I think it's reasonable to try and fuse this without, or heal this without fusion, rather.
Okay, drum roll, Dr. Plumer, what did we do?
So interestingly, there was a long discussion, but we ended up with non-surgical care. The patient was braced, and yeah, she was able to void and was able to pass gas before she was discharged. And in her 3 months visit, she was near intact. She was good from the pain standpoint, and also wearing her brace. And the bowel bladder dysfunction was resolved, but she was still on oxycodone. And this, I mean, we only have a standing film from the 3 month visit, and it actually shows a little coronal, coronal disbalance, but otherwise she was, clinically, she was doing good. Yeah.
So Dr. Hart, ISSG, what are the tolerances of deformity in the coronal and sagittal plane post-traumatically? We obviously assume that this is a very engaged patient. She is very smart. She's an accountant, and her mom, very engaged, very healthy, very compliant. We did the Chapman stability test, neurologically intact patient. We gave her a brace, we stood her up, we watched her carefully how she felt, and she felt, quote, great. So we got upright x-rays. They looked okay, not great. We obviously documented this coronal and sagittal deformity, and we let her go. We followed her in a very close fashion every 2 weeks for a while. But what are the tolerances of deformity? Is this unacceptable? Is this patient going to be okay? I mean, clinically, except for occasional oxycodone right now, she's actually doing great.
Yeah. Well, I accept that I've been proven wrong here. I think I will say the deformity on that standing film looks much better than the deformity on the CAT scan. And if her early mobilization films looked like that, I think I would have accepted that amount of deformity. I don't think this is going to be a great limitation to her. And I don't think we have data on this, but certainly it's less than 25 degrees kyphosis. And that amount of coronal deformity, if we saw that in a small idiopathic curve, of course, we would all say, you're fine, you don't need intervention, and you don't need follow-up necessarily. So I think you got her through a moment of crisis without an intervention, so I congratulate you.
No, thank you. No, it was, this is again parenthetical for non-operative care. I think the amount of time we spent talking about things, and our administrators won't be happy because we actually had this patient in the hospital for, I think, 5-6 days or something like that, because we basically had to get her through her urologic situation. We did a gradual post-void residual program. We installed a formal bowel program. We got several abdominal ultrasounds to make sure there's no occult secondary abdominal violation. As we know, the intestines can kind of perforate secondary. Oh, great.
Just to this one,
Yeah, why don't you talk about that quickly?
Yeah, just one slide. This is the yeah, this includes only 2 papers, and so in seatbelt syndrome, so seatbelt signs, we always should be looking at the intestines. So intestinal injuries are rare, but if they're overlooked, they can be life-threatening. So what's common, the small bowel is injured more frequently than the colon, and you should always be aware of these injuries, that they can happen, and anticipate them. And how can we actually find them? The standard of care today is a combination of X-rays, CT, and repeated ultrasounds. Back in the days, that was based on the ATLS algorithm, more like a different approach to this, but the actual care today is X-rays, CT, and repeated ultrasounds. So,
and we would have obviously fixed the spine had there been an abdominal violation. It's not even a question, or a neurologic problem. We're very, all the points made by all our, this was not a case to show everybody up. Every one of the considerations is very valid. There was no neurologic injury. We're worried about the bladder. We felt, just like what Dr. Hart said presciently, this might be an opiate side effect. So that was that. Great cases, thank you, and thanks for the great discussion. And it's a great honor and pleasure to introduce our guest speaker, Dr. Holland. Thank you again, Jonathan, Mauricio, and Jimmy. So Dr. Holland is a board-certified neurosurgeon at Carolina Neurosurgery. I should say Carolina Neurosurgery and Spine. He is MD and Ph.D. from Boston University, did his residency at Emory, and did his fellowship in the University of Utah system with Drs. Daly and Brodke, and others who are near and dear friends of ours. And again, he's going to talk about simultaneous prone position, corpectomies, and instrumentation, making good use of navigation and robotic aids. So thanks for being here this morning. Thanks for your sage comments, Dr. Holland, and we look forward to learning from you.
Thank you very much. I'm really excited to be here. These were great cases this morning, and a great lead in to talk a little bit about prone lateral. I'm not showing prone lateral corpectomy today, so I apologize. I am going to talk a little bit about prone lateral in general, and really the optimization of that approach, and where I see the value, as well as the integration of robotics and navigation there. So here are my disclosures. I do primarily spine surgery. It's 95% of my practice and the entirety of my elective practice, and have a longstanding experience with navigation and robotics from the early stages where we were doing point-based registrations, and really into the current state of technology, and use them both for open and MIS deformity techniques as well. Today, I really want to talk about minimally invasive lateral fusion and its evolution into prone lateral. In particular, the values I think we see with lateral approaches continue to expand, both from a technological standpoint as well as in terms of indications. I think, in the past, we've had to stage these cases, and several of the cases that we talked about today, where we're talking about staged anterior and posterior access, can be facilitated in a single position, with either single position lateral or single position prone more recently. But there are limitations in terms of what we can do with both of those approaches. The recent interest in single position surgery, in part are in terms of reducing surgical time, repositioning challenges and contamination risks, and people have explored both single position lateral and single position prone. And both of these, I think, are greatly facilitated and enabled with the use of navigation and robotics. So the lateral approach that I use in my practice, and that we use quite a bit here at CNSA, is more of a direct lateral pre-psoas approach. So not an oblique lateral or anterolateral approach, but direct lateral with mobilization of the psoas muscle dynamically. I tend to not use fixed retraction at all for my lateral cases in a lateral position, but we'll talk a bit more specifically about prone lateral. I think there's a lot of value here in terms of direct visualization, minimization of psoas trauma or hematoma. We don't see the same neurologic complications that we would see with the folks that we were doing trans-psoas lateral approaches on, in terms of anterior thigh pain, paresthesias, and other transient neurologic effects. It's able to facilitate both a left or right-sided approach, and really that approach can be tailored to the patient's anatomy, curvature, and pathology. It does not require intraoperative monitoring. You can minimize the use of fluoroscopy because you're working directly orthogonal to the spine, and you're using straight instruments, so not this oblique lateral approach where this orthogonalization maneuver within the disc space. The workhorse of lateral approaches for me are these old handheld retractors here. You see at the left, the Wiley retractors. I tend to use these all the way from the skin down to the spine to divide the muscle fibers, access the retroperitoneal space, and then mobilize the psoas muscle posteriorly. On the right here, in terms of disc prep, I utilize these partially rasped trials, again, as the workhorse for my disc work. And those have gone through several iterations as we've developed and refined those. Initially, when we began using these rasped trials to do our discectomy and prepare our end plates, they were entirely rasped, which we found pretty early on. They would get stuck in these degenerated and collapsed disc spaces. In the picture at right, that's Dr. Sam Tuning, who recently retired this year after a very long career in spine surgery. And his favorite role is to play the tour guide for a direct lateral approach. He likes to hold the retractors. And a few years ago, I had to buy him this helmet after he took the slap hammer to the chin when we were trying to remove one of these fully rasped trials. So the design of that device has evolved since then, but I think if Sam were to come in for another lateral with me, he may wear that helmet still. So here's just a brief video just showing this lateral approach and the disc prep here. You can see that we're mobilizing the psoas muscle for direct visualization of the lateral disc space and lateral vertebral body. This is really facilitates discectomy, cage placement, and allows us to work really orthogonally without having to take what I see in many lateral publications or videos. The fluoroscopic imaging looks like a stop action movie with several shots in and out of the disc space with every single instrument. Once you define the anterior longitudinal ligament and your position within the disc space, you can work orthogonally up and down with your instruments in and out of the disc space without having to shoot fluoro. And oftentimes, once we've identified those landmarks, we can perform a lateral discectomy at many levels without shooting an image at all and without the requirements for neuromonitoring. So that was just an example of a single level standalone cage here. Here, just to show sort of the transition with this technique from one level to the other. This is a brief video here. You'll see the cage that we've already placed at the level below. We just move up to the next level, and you can see the white annulus there below that small vessel. We can coagulate and divide that vessel, but we can already visualize the next disc annulus there. And once we divide this vessel, you'll see that we're going to move very quickly up to the next disc space and be able to start our next discectomy. So again, the nice thing about this is the efficiency. So in the time it takes one of my partners to size and set up their fixed retractor, I've already moved to the next disc space and have started my discectomy and I'm ready to go on from there. So very quickly to move from one side to the other. Once we mobilize the psoas posteriorly, we can do a subperiosteal dissection on the vertebral bodies, resect osteophytes as needed, access the disc space, do our anterior column release, or if we were doing a corpectomy here, for example, we've now got complete visualization of the vertebral body between the two disc spaces and can begin working right away. Once we relax the retraction of the psoas muscle, it falls back into place. You can see here the psoas muscle is released. There's no trauma to it whatsoever. It falls right back into place across the disc space. And so really we're not seeing the same issues that we saw with a lot of our transpsoas lateral work. And these patients mobilize very quickly and don't have a lot of that anterior thigh pain or hip flexor weakness that we saw with a lot of our transpsoas work. In terms of experience with this technique over the last 5 years, I've done about 204 patients. 81 of those have been deformity cases, about 403 levels of lateral with this technique, 24 anterior column releases, and 7 vertebral corpectomies. Early on, I was using neuromonitoring quite a bit, and so there's a 20% neuromonitoring rate overall. But in the last several years, this has been less than 8%. This was mostly in our early experience for severe deformities or when working trans-psoas in the prone lateral position. The values of single position lateral surgery are clear. It's efficient. We decrease operative time, and there is some thought that we may be facilitating the generation of lordosis, particularly in a prone position. There are some limits as well. Whether or not we're able to get anterior to the psoas and mobilize that psoas in a prone position has been challenging. I've had a case or two where I've been able to do that and not have to go trans-psoas, but in the majority of cases, it's quite difficult to do because you're not only mobilizing the psoas, but you're trying to retract it against gravity. There may be some concern with short segment. I know there are folks out there that are doing 4 or more levels in prone lateral. For me, I don't like going trans-psoas across that many segments. And I also, at the upper lumbar or lower thoracic spine, like to take that rib, as I mentioned earlier. And to do so, I think that's greatly facilitated in a lateral decubitus position. There are challenges with morbid obesity. In a prone position, the belly tends to fall away, but their abdominal girth or width is increased. And so we use a retractor in those positions. It tends to be a longer retractor. We're working with longer instruments. It's a bit deeper. And with single position lateral, in a lateral position, placing those inferior or contralateral screws can be challenging. And here, obviously, navigation and robotics have been helpful. There are some papers showing significant screw misplacement or breach rates with fluoro guided screws in a lateral position. With single position prone, it facilitates things that we're not able to do in single position lateral. Posterior decompression or TLIF at adjacent segments are two of the major benefits. There are poor lateral ergonomics, but there are some ways that we're improving that. And there's a need for a lateral bolster. I personally feel that this is one of the critical components for prone lateral surgery. There are a number of things that can be helpful, but really the lateral bolster, contralateral bolster is key. There are some series that have been published looking at single position surgery in terms of longer operative time, reoperation rates, but without the significant differences in lordosis or overall complication or outcome. But certainly screw position in a direct lateral orientation has been challenging. And so when we do our single position lateral, obviously patient positioning can be an issue. Body habitus and rotational deformities are a challenge. And you are unable, for the most part, to provide access for a posterior decompression or posterior interbody work at adjacent levels. But the familiarity of the lateral position for lateral access is certainly beneficial. Dr. Pimenta first described prone trans-psoas approach, which allows for simultaneous lateral and posterior access, giving a single position circumferential approach to the spine with optimization of gravity to potentially improve lordosis and a streamlined workflow. And the patient selection and indications and contraindications are all really similar to trans-psoas patient selection in general in terms of psoas and vascular anatomy considerations. The prone positioning is familiar for the OR staff. It's a lot faster and less time consuming, but you need bolsters and pads to aid in tilting the bed to allow for approach access. And that lateral bolster can improve the ability to break the bed, giving you access to L2-3 or L4-5 as needed, where the iliac crest or the ribs might give you some bit of a challenge. And it can allow for a pre-psoas or anterior psoas approach in selected patients. Early on, here's a sketch where I began thinking about how to make a lateral bolster, not just to have something to impact against or impose your impaction forces, but also to provide some coronal break for access. And initially, I'll show you some pictures where I was making these out of foam and small hip pads and using tape to sort of break the patient or open up the space between the ribs and the crest for access. And now we've got some really nice patient positioners that can do a lot of this work for us. The patient has to be secured pretty well to allow you to rotate the table some for improved ergonomics. If you want to leave the table flat, you also need to raise the bed quite high in order to be able to work. And this can be done in a seated or standing position. Here are some early pictures. You can see in the center there where I would make a bolster out of foam and pads, and then I would use some tape to not just pull down on the hip, but also break the patient across the bolster to give me improved access as needed. Here is the novel patient positioner that the folks at Globus have worked to develop. We've been working on this for some time, and there are a number of advantages. You can see that in addition to the pads for the chest and the hips where the patient sits, there are bolster pads on the sides to further support the patient's rib cage and pelvis, as well as the radiolucent contralateral bolster to allow a fulcrum to break against and also to oppose the impaction forces. The rigid arm for the retractor, as well as the retractor itself. I think, again, the contralateral bolster is the key here, but there are several other nice features. The chest and hip components of this positioner rotate independently and can give you about 25 degrees of maximal coronal break to improve access. There is a built-in 15 degrees of tilt, so you have an increase of additional 15 degrees of bed rotation that you can get with this positioner. And so in order to neutralize the patient flat, you go to a negative 15 rotation. And if you go to maximal bed rotation, you get an additional 15 degrees, providing you with better access and better ergonomics. And then there's obviously the rigid arm for the retractor and a prone-specific shim to fix that retractor into the disc space. When we look at some of the early single position prone cases, one of the benefits is that you can keep AP fluoro in the field, which bringing fluoro in and out was always time consuming doing these in a direct lateral position. Obviously, looking in the center there, the ergonomics are not ideal if you don't rotate the bed or lift it. And so you don't want to spend your cases doing what I'm doing there in the middle. Certainly being seated and allowing for some bed rotation is really beneficial. Unlike the direct lateral technique that I use, really when we're in a prone position and you do some bed rotation, navigation and robotics are really beneficial here, especially when you're working off plane. And so once you've rotated that bed 15 or 20 or 25 degrees, it's much more difficult to orient yourself along the disc space and make sure that you're remaining orthogonal as you're working. And having navigated disc prep and navigated interbody placement options is really a huge benefit here in particular. In terms of early experience, we do find that the psoas does move somewhat more posterior with the hip flexion in the prone position. It does tend to facilitate, for me, L4-5 access. The retractor can tend to shift anteriorly due to gravity, and you're finding that we're using longer blades with those retractors due to abdominal girth. There have been cases described of inadvertent ALL disruption or violation due to that anterior migration, and you really have to be conscious of your working angles, especially with that bed rotation, as I mentioned before. In some patients, particularly larger patients like we have in North Carolina, lateral position is still going to be ideal for that approach. Navigation and robotics really have improved the ability to perform prone lateral surgery, not just with placement of posterior instrumentation, which can be facilitated at the same time as the lateral work, but using navigated disc prep tools and interbody placement instruments is really helpful with a significant reduction in radiation. There are fluoro challenges with true AP and true lateral. I'll talk about some advanced imaging solutions there, but you are able to leave AP fluoro in the field while you're doing your lateral work. And there can be a bit of a learning curve to maintain a proper working trajectory. And this could require more fluoro than I typically would use for a lateral without the use of navigation or robotics. Advanced imaging solutions are really helpful. Here's the Excelsius 3D, which is a fluoro digital radiographic system, as well as a 3D cone beam CT system. The nice thing about this system is that it has position memory. And so you can rotate this machine in a position. It moves very easily on these omnidirectional space vehicle type wheels, but it will remember positions within the room. And so if you have your bed rotated and you finally get your ideal AP and lateral images, you can return to those same positions and retake those images as needed without a whole lot of adjustment this really is beneficial in these positions when you're working off axis. The robotic technology, again, as I mentioned, greatly facilitates not just screw placement, but now with interbody disc prep instruments and cage placement instruments as well. We can really navigate all of the work being done both laterally and posteriorly at the same time, and really helps to reduce fluoro and provide some confidence when you're working not in a entirely orthogonal. So overall, I think prone lateral is a safe and reproducible approach that allows you to access the lateral and posterior column simultaneously. For me, it facilitates this circumferential approach in patients that are going to need it for multi-level lateral fusions for first stage deformity. For example, in those cases, I'm still doing them in a lateral position and flipping them. I find in my practice, the real advantages are the patients that need 1 to 3 segments addressed and are going to need some sort of posterior work done in addition to their lateral fusion beyond just pedicle screws alone. And I think it's a good alternative to lateral transpsoas approach in selected patients, but certainly patients with extremely high BMIs or wide abdominal girths may be better suited for a direct lateral in the lateral position. I think it's an opportunity here to streamline surgical access to the lumbar spine with the potential to improve lordosis, fusion rates, and clinical outcomes. There are certainly potential economic advantages with improved OR efficiency. And it requires, continued improvements. The improvements of our retractors, disc prep and interbody instruments and implants, and robotics and navigation have really facilitated this work. Again, working off angle with free rotation of the bed and being able to track those instruments in real time through the disc space, as well as to plan your constructs in advance. I think there are huge advantages there. And I think that the interest in single position prone has surged in the last couple of years. I'm always a bit weary teaching at courses where there are folks that have no lateral experience whatsoever who are coming to learn a single position prone, as I do think there's a bit of operative nuance here and certainly significant risk in this position were you to get a vascular injury or otherwise. And so I think it's important to have some experience and familiarity with the lateral approach and lateral anatomy before moving to a single position prone technique. But I think interest here is growing and will continue to grow. Thank you very much. I know I went through that somewhat quickly, but I wanted to leave some time for discussion or questions. And I'd be happy to go back as well.
Very nice, great shot, great family shot. Thanks so much for this overview. Can you go back to that positioning slide? This is great juxtaposition. So Dr. As you know, Dr. Skuyan is one of the pioneers together with Pimenta and Uribe on far lateral surgeries. And again, if you go back to your slide that showed the 3 different positions, how comfortable are you, let's say in a corpectomy, to actually get a good decompression of the ventral neural canal? I mean, you showed us very nice placement, very efficient placement of interbody spaces, but not of neural canal decompression from anterior. So how comfortable are you to actually decompress the ventral neural column, let's say in a burst fracture?
So I think it can certainly be a challenge. I think the challenges we've had relate not just to patient position, but and access, but also visualization. And so, again, for me, when I'm doing those burst fractures from a lateral approach, I'm mobilizing that psoas, and I've got very wide visualization, so I can work very comfortably decompressing the ventral spinal canal. In a prone position, it's much more challenging to do that. And if there's somebody with significant retropulsion, I'm going to do that in a lateral position and not in a prone position. If it's somebody without significant canal compromise, it doesn't need a lot of ventral canal decompression. And I'm really doing the corpectomy more for anterior column support, then I think that can be facilitated fairly easily within the prone position. But I think you're right. I think you're hitting the nail on the head. I think ventral column decompression in a prone position can be a challenge. Now, being able to rotate the bed up through 30 or 35 degrees, so you're almost working in more of a direct lateral orientation can potentially facilitate that. The use of navigated instruments, navigated drills, and osteotomes can also facilitate that access. But it really comes down to direct visualization for me, especially working in the ventroepidural space. And so I need to be able to see that well enough to get it decompressed effectively. I hope that answers your question.
Yeah. So can you go back to that slide that showed those position things, if that's not too much of a hassle? Because that was a very cool juxtaposition of different positions. So Rod, you're a master of XLIFs, and I see you doing less and less. And we've in the lab here done several prone position corpectomies and all that. Where are you? Where do you see the benefits? And do you absolutely need a robot and a navigation device to do those safely?
I mean, I think the holy grail in lateral surgery is the lumbar plexus. I think if you do it prone versus lateral, it's really surgeon's, choice. And for me, Chris, and I don't know what your thoughts are, is I think it's more about the plexus and neuromonitoring. I think robotics, all that stuff is great. I mean, there's no question it's super helpful. But I think you got to know where the femoral nerve is, especially at 4-5, and you got to understand the anatomy, whether you're prone or just doing it lateral.
I completely agree. I think navigation and robotics are great adjuncts, and I think they help a bit with trajectory. But for me, it's visualization. Once I'm within the disc space and I know where my ALL is and I understand my orientation, it's all of that is feel and direct visualization, and that's where the value is. And when I'm doing them in a lateral position and I'm mobilizing the psoas, I know where my plexus is. And even in those patients where a lot of folks that work transpsoas would shy away due to the morphology of the psoas muscle and the anterior migration of the plexus, I feel some of those cases are the most they actually facilitate a psoas mobilization and a direct lateral approach, because the psoas isn't really attached at that segment. And in gradually mobilizing the psoas backwards, you're mobilizing the plexus as well. And so the other nice benefit with dynamic mobilization is that there's no fixed retractor time. And so we don't worry with a corpectomy in terms of having a big open retractor for an extended period of time. I have started using a rigid surgical arm called a Walter to fix one of my handheld retractors that allows me to get quickly back into and out of the same place with my dynamic retractors as I come in and out to take X-rays or fluoro images. But I agree with you. It's about the plexus, it's about monitoring, and it's about direct visualization more than anything else.
So you do use monitoring on all of your patients?
So I do not use monitoring in general for my patients where I'm doing a direct lateral in the lateral position. I monitor all of my prone lateral cases because in the majority of those cases, I'm going transpsoas at least one of the segments, sometimes more than that. In my lateral approaches in the lateral position, I'll monitor in patients with severe deformity. But in the majority of cases, I don't.
Great. Now, it's certainly nicely done how you, and the video was very cool. What are the limitations of anterior fixation? So this is something I struggle with, and that's this outpatient surgery mentality where we see patients kind of getting build-ons with far lateral procedures with supplemental plates. And that kind of goes well 1 or 2 times, and then they come with an L2 burst fracture where the vertebra just literally splits because the cage is just split right through the vertebra that was put in at L2-3 below. I'm sure you've seen that also. They've had a career of about 3 or 4 outpatient surgeries until they reach L2, and then L2 blows apart, or the cage just kind of wobbles loose. So this is a frustrating kind of a later effect that doesn't appear on the immediate quality control things, which for outpatient surgery centers still are very insufficient. So what are the limits of anterior fixation? And then we'll have to get going.
Sure. Yeah. So I've got a series of close to 35 or 40 patients looking at standalone lateral in elderly patients, and those are cases from really 2 to 4 segments with correction of coronal alignment and indirect decompression without supplemental posterior fixation. And I think patient selection here is important. Again, we're operating on patients that are older, but still active. I have a patient who is 86 years old, who I would not consider an L2 to the pelvis operation, but was able to successfully do standalone direct lateral fixation. I tend to use integrated screw fixation and not lateral plates anymore. But that patient is 2 years out from surgery with solid fusion, dramatic coronal correction, and is pain-free. There are some failures. I've had a patient who had numerous back surgeries, who was an end-stage renal patient with diminished bone quality, who had a 2-level direct lateral above her prior fusions, fell and had a burst fracture between the 2 lateral interbody cages. So she had a 2-3 and a 3-4 direct lateral, fell and had a L3 burst fracture with a lateral migration of one of her cages, and required a more comprehensive revision. And so we see that. We're in the process of trying to write up some of our standalone anterior work in patients over 65 and 70, because ultimately, in our series, we've had great results there, but paying particular attention to bone density and end plate disruption is critical.
So last question from Dr. Patari. Given bone quality, how does a lateral approach work for high-grade listhesis? Are you comfortable doing that? You showed that L4-5, grade 2, maybe 3 spondylolisthesis. So are there any tips or tricks? Are there any particular concerns when you have a patient with a higher grade spondy?
Yeah, absolutely. So one, I like anterior interbody fixation in patients with low bone quality, because I think the larger footprint can help you to avoid subsidence. I'm very careful in those patients, specifically in patients with severe disc collapse, that I tend not to use a mallet at all, particularly with the cob, which is quite sharp and it's easy to migrate into the end plates or into the vertebral body. So I tend to use my very small blunt trial rasps that start at 5 millimeters. And I tend to wiggle across the disc space as opposed to mallet, in order to open that up and mobilize it with because the key is preserving the end plates. You have to be acutely aware of the end plates there, and getting an end plate defect in a patient with poor bone quality is going to give you immediate, if not really short-term subsidence.
I want to thank you for your lecture. Dr. Özgürün will take us out from here, but thank you to our audience, and thank you. I learned a lot. And Dr. Özgürün, any closing words on your end?
No, great job, Chris. Those are great cases. I love lateral surgery, so it's cool to see the prone stuff getting out.
Thank you very much. Thanks for having me. I thought this was great.
Thank you to you, and thank you to Globus for sponsoring you and all of our.
Thank you.
Okay.
Thank you, Jens. Thank you, Christopher.